I have a slide session with zombie movie. Okay. So when we bury people, we don't try to put them 30 foot in. Just 6 feet is plenty. In this situation, what I'm relating this to is the vertebrae are too deep. So I'm taking some of the dirt off so they're close to the surface. Okay? Now in the mid-back, or any place else, they had hyperkyphosis, which again, mid-back is the typical place. Now, the bodies are rising. We don't want that. We've seen what happens. They come after our brains. Things are bad. So instead, I want to add tissue, put a little more dirt on the pile, so there's more pressure, so there's more resistance to them continuously moving in that direction. So in this section, I would move her tissue from lateral to medial. Again, she doesn't have an excessive kyphosis, so I'm not doing a bunch of deep stripping here. Just showing the proper direction. If somebody's got good curvature, then either just try to keep the work even to maintain what they've got. All right. So if they're too far forward, I'm going to move the tissue lateral. If they're too far posterior vertebrae, I'm going to move it medial, cover it up, cover the zombies, put the dirt back on top. All right, you can use that throughout the spine, vertebral column. What if we find they've got a situation where they've got a lateral curvature? Now, during lecture, you guys were talking about lateral curvature. Scoliosis is typically, they try to assess it very early on in the developmental stages, like junior high, middle school, because that's when your bone and skeletons are growing the most. If you wait until you're in your 30s to try to correct scoliosis, we're not at a position of correcting scoliosis once your skeletons form like that. We're in a position of maybe we just take some tension off and help you just stay how you are, okay? But chiropractors will perform and scoliosis correction therapy, especially in that developmental stage. And massage and chiropractic are just most effective together. We work the soft tissue, they work the hard tissue. Together, we accomplish more. So, if somebody had a scoliosis here, let's say we've got a curvature going this way, right here, I would expect that Elena or Ryan's side, which one's going to be bulging? Elena's, because as the curve happens this way, this tissue on this side bunches up. This side is going to be nice and flat. Which side do you think they feel their pain on more? Elena's or Ryan's? Ryan's, because this tissue is being stretched, overstretched. But just like we talked about the rhomboids back in the day, if I do a bunch of work, medial or lateral in this area, I'm lengthening that tissue. I don't want to lengthen that tissue. So on the flat side, just like on the rhomboids, we work vertically. You can work pretty intensively through the lamina groove, trigger points, rotatores, working along the actual bodies of the superficial erectors. That's all fine, but we work vertically. On the bunched side, where the vertebrae are being pulled over, we're talking about like a section of vertebrae. It could be a full curvature, it could be sometimes 2 or 3 vertebrae all shift over at the same time. I want to work that tissue back towards the vertebral column.
I had a client where her ribs were actually bulging.
Yep. Yeah, because the vertebrae have twisted so much, the rib heads have gone with them, and their rib cage will be visibly higher on one side.
When I was palpating, there wasn't much tissue really
Because
on the side of the
it's been
ribs.
stretched flat.
Yeah.
Yeah. So we can assess our client's vertebrae. What I do is I just stack my fingers like so. It leaves a little tiny gap where my index finger is, and my middle fingers are down inside the lamina groove. And I just glide straight down. And as I do that, I can follow the natural curvature of the vertebral column. And so as I go down, I'll go ahead and point out, right there you go, a little sensitivity. Right there, did you have some?
Yeah.
There's a tiny one. Anything there?
Mm-hmm.
So I know where she's got a little more sensitivity, because as I was going along, I can feel where the vertebrae are subluxed. I don't tell my client that, because that would be a diagnosis, right? We've talked about subluxation. It's just a vertebrae. The bone is slightly out of position. In this case, the vertebrae is slightly twisted. Now, if she had 2 or 3 that were all twisted in a chunk, I would do that correction I just talked about. But if I've got one vertebrae that's twisted and hers were moving as a group. Oh, there's one. That one, you feel?
Mm-hmm.
Okay. So this one, if these are her 3 spinous processes, this one's towards Ryan. I can feel that it's shifted over.
Mm-hmm.
So I can approach, now this is, again, I'm going to push on the vertebrae. But my intent is not vertebrae. My intent is fascia. I know that the rotatores on this side are pulled tight. The fascia is probably settled into this position. And that if I can really get the rotatores to stretch and the fascia to stretch with it, then the vertebrae is likely to fall back, and it's actually just started moving. What I do is, so imagine a vertebrae's got 3 pieces, spinous process and 2 transverse process, right? The spinous process, it's all twisted this way. So I'm pushing the spinous process back to the other side. And the transverse process, a lot of times when the whole vertebrae shifts, it starts to poke up. So I'll push the transverse process down into the body. Spinous process, back the right direction. Transverse process into anteriorly towards the table in this situation. Again, my goal here is I'm not doing some high-speed chiropractic adjustment. I'm applying a stretch. I'm just like when we stretch the bicep, we straighten and twist the forearm to stretch the bicep. I'm pushing on the spinous process of the vertebrae because I know the rotatores has to be attached to that. And so if I can apply a stretch to the spinous process, it's transferring that stretch into the rotatores. And it will slowly, if the body trusts me, it'll slowly start to realign. And it's a little bit better, but it's still there. You can still feel it, yeah?
Mm-hmm.
Yeah, it needs more. So that's how you would adjust it. Probably not that word. This is really important, this terminology, because it matters what we do. What I'm doing is myofascial, but I'm using the bone as a lever. But we have to be very careful about our scope of practice and our limitations, and our vocabulary matters a lot to that. So if a chiropractor finds out you're doing myofascial release around a vertebrae, well, that's fine. That's myofascial. If you tell them you're adjusting bony position to correct subluxation, your technique might be exactly the same, but you just crossed a line into bony adjustment, which is illegal. It might seem like semantics, but sometimes legality is a lot of times about semantics. So myofascial release around vertebrae, allowing the skull to fall back, the skeleton to realign itself is fine. Jamming bones or any back into position is not. Okay? All right. And that was the end. Any questions? Okay.